Okay, so there are three main factors for clinical assessment for someone with frozen shoulder that comes in your door. To me, assessing the shoulder at neutral here is going to be very huge. I don't like to assess in higher ranges because then a lot of other conditions can come into play. One of the big things that I look for is if I can passively rotate the person's shoulder to external rotation more than 30 degrees. If it's less than 30 degrees, it really tells me a lot more. So that's pretty much a very sensitive factor. And also one thing you want to check for too is obviously the infield as you get to external rotation. But usually pain at end of external rotation will be a telltale sign too. Usually that can be indicative of a frozen shoulder or something like subscapularis tear, which is not as common. Another clinical feature that I like to perform just as a screening tool is typically with someone with rotator cuff dysfunction, they're going to have pain to provocation, preferably in the subacromial space, either anteriorly or laterally. Someone with frozen shoulder typically doesn't have that if it's just true frozen shoulder, unless the rotator cuff has issues too. But that will help drive whatever treatment you want to go with from there. And the fourth factor I really incorporate too is where their arm is by their side. Is typically with your rotator cuff dysfunction, it's going to be pain with manual muscle testing against external rotators. And usually internal rotators with someone with frozen shoulder, someone with rotator cuff dysfunction, it's going to be pretty strong and painless. It's going to be weak and some of the time painful if they have frozen shoulder. So hold your arm like that. So you just test internal rotation, and usually if it's a freezing stage or frozen stage, that will be a lot weaker than normal.